Welcome to our presentation today, a deep dive into family-focused therapy with Dr. David Miklowitz. For those of you who are new to CMHRC, I'd like to introduce myself. My name is Elizabeth Errico, and I am CMHRC's Executive Director. And our mission is to provide guidance and resources for early identification and management of mood disorders, including bipolar disorder and its newly identified phenotype known as thermoregulatory sleep dysregulation disorder, or FOH, as it's more commonly known. Tonight, we are going to talk about family-focused therapy, when it is appropriate, and what evidence-based practices are used in tandem for maximum benefit. We're going to explain the core phases of family-focused therapy and describe how family-focused therapy principles work in order to meet the needs of diverse family structures and cultures. And we are very lucky to have with us here Dr. David Miklowitz. He is the creator of family-focused therapy. He is a professor of psychiatry in the Division of Child and Adolescent Psychiatry at the UCLA Semel Institute. He is also the Senior Clinical Research Fellow in the Department of Psychiatry at Oxford University and the author of Bipolar Disorder, a Family-Focused Treatment Approach, the Bipolar Disorder Survival Guide, and Living Well with Bipolar Disorder. So I am very pleased to welcome Dr. Miklowitz with us here tonight to talk with us about family-focused therapy. So let's get started with just allowing you to sort of introduce yourself a little longer so that you can tell us a little bit about the creation of family-focused therapy.
Well, first, Elizabeth, thanks very much for inviting me and for doing this. I really appreciate the opportunity. As you know, family-focused therapy is our treatment for kids with bipolar disorder, kids at risk for bipolar disorder who are in the early phases. And we're also using it with actually adolescents and young adults who are at risk for psychosis, who have early signs of psychosis. So my history with this really goes back to graduate school when I was an intern at UCLA. And at the time, I was studying schizophrenia. I had an advisor who was very interested in families and family processes in schizophrenia. And as it happened, I was assigned running a bipolar support group as part of my internship. And I realized very quickly, these are my people. And I recognize myself in some of what these folks do, and they were very personable and kind of, some of them were kind of larger than life and very supportive of each other, able to help each other in ways that were, I think, much far beyond what we could do as clinicians, recognizing when another person was really suicidal or not. And I just got interested, and partly it was because the members of that group talked a lot about their families and how interactions with their families really triggered episodes in one case, or were supportive against being hospitalized for an episode in other cases. But their family was clearly a very important influence. The work I had done in schizophrenia had been about family education and how does what's the role of the family in schizophrenia? And it seemed like an obvious jump to apply it to a different disorder. And that became my main interest, was how do you treat families where somebody has bipolar disorder? How is it similar? How is it different than other disorders? What's the role of medications? How can families be supportive? What do they do wrong? What do they do right? And how should they know? And how can clinicians help them? Now, that's compressing a lot of history into a couple of sentences, a lot of twists and turns along the way. I was at UCLA.
Sure is.
Yeah. I was at University of Colorado for a while, and then came back to UCLA in 2009. And that's now I run a mood disorder program for kids and adolescents.
Well, I think what I'm hearing, though, as the through line here is that it really was built out of the clinical work of needing to
Yes.
find ways to bring relief to families that
Yes.
were struggling with these disorders that maybe weren't being properly managed.
Yes. And it's probably worth pointing out that there's a kind of a long and negative history of psychiatry with families. There were the double bind theories in the 1950s and the schizophrenic mother and the refrigerator mother for autism, and everything was mom's fault. And it was
Mhm.
sort of it was a kind of psychoanalytic view of these psychiatric disorders. And when so much research came out in the 50s and 60s on the genetics of these disorders, both bipolar and schizophrenia, and the role of medications. We really had to rethink what is the role of the family. Can the family be a supportive influence? What do they need to know to help the person? Uh, what when is it appropriate to set limits with someone who is psychiatrically ill, and when is it not? Those are not obvious questions, I think. And we really had to put a lot of thought and effort into what that meant and how to do it.
Well, and I think you're touching on a really important point that families encounter all the time when they are engaged with the psychiatric and psychological care systems, that there is a lot of blame that's put at the foot of the family. That if parents were only uh, more better disciplinarians, more consistent with consequences, et cetera, they would somehow be able to rid their child or loved one of their symptoms, which is a fallacy. And it's one of the things I love about family focused therapy is that it reframes that lens away from blame and onto skills and tools that can be learned in order to improve the situation. So it really is providing them with a sense of agency.
Yes. That's certainly the goal. I appreciate you saying that. What we tell families at the very beginning is bipolar disorder is affected by the family, and the family is affected by bipolar disorder. It's very much a bidirectional relationship. When someone's getting manic, you can't point to the family and say, "Well, if you'd done this, they wouldn't have gotten manic." Of course not. The question is, what do they want to learn? What to help the person, to keep them in their household, to help them stay stable for lengths of time. We don't pretend like we can cure anybody of a lifelong disorder, but we certainly can make life easier for the family and for the person. And that's our goal.
I'm curious how you find families respond to this idea that it's not a cure, it's a management tool.
It depends upon where they are in the course of illness. If it's at their first episode, the kid's first episode, or the young person's first episode, or maybe in the prodromal stages, there's a lot of resistance to the idea that this isn't curable. But the truth is, when someone's only had one episode, we don't know whether they'll have another one. Chances are that they will. If they've had a pure manic episode, there's a good 80% chance they'll have a second one, but we don't know when that will be or how serious it'll be. It all depends upon what treatments they get. We also know that some kids seem to do well over time, uh, partly from supportive families, but also just good old resilience that they have, or the way they cope, whether the way they stay on treatments, or how well they understand the disorder themselves. Some people go years without having episodes. But I think the family is armed against this disorder much more if they realize it has a chance of recurrence and being able to recognize when that's happening.
So before we dive into really talking about the different components of it, I wanted to bring up the fact that last fall we had Dr. Dimitri Popoulos and Dr. Robert Post on for an event where they had written a paper that looked at treatments in bipolar disorder, both medicinal as well as psychotherapeutic. And one of the things they talked about was their sort of literature review of psychotherapeutic treatments for bipolar disorder and how family focused therapy really stands out in the literature as being one of the most effective ways of treating bipolar disorder in youth. And so I'm wondering if you have any details that you could share on on outcomes. What does it look like when a family truly engages in FFT?
Yeah, I have done 13, 14 randomized trials now involving family-focused therapy. Usually the design is we take in people who have had an episode recently. We randomly assign families to family-focused therapy with and the person to medication as well, or some sort of comparison condition like case management or briefer family education or supportive therapy. And we consistently find that the people who get the family therapy with medications do better over time. They have fewer recurrences, they do better psychosocially, they have better quality of life, and their families are doing better on the whole. It doesn't mean that every person who gets treated is going to have a wonderful outcome, and we've had negative outcomes as well. But on the whole, it's a pretty powerful treatment. We did, when I say we, myself and my colleagues at Oxford, did a meta-analysis on all the psychotherapy studies in bipolar disorder. And I wasn't the one who did the actual statistics, so I can't claim to be the cause of this outcome. But the two findings basically were that among the different therapies that were being tested, the two that were the best in terms of preventing or delaying recurrences were family and group therapies, much more so than individual therapies. There was some role for individual therapies with stabilizing depression, like CBT, I think is effective in that regard, and interpersonal therapy for sleep wake cycle stabilization. But in terms of recurrence, it really involved having advocates for the person, whether that's in a group or in the family setting. That's partly why we think it's effective, is because there's more than one person on the treatment team. You're not just sending the person home and saying, hey, when you get manic, call your doctor, because insight goes out the window when you're manic.
Exactly. And mania can feel good. And
Yes,
so why would I call my doctor when I'm feeling good?
exactly. Yeah. I've heard it compared to being in love, is
Mm.
that, when you get manic, it's sort of like being in love. It'd be like someone coming along and saying, gee, would you like to take this pill to not be in love anymore?
A very vivid analogy puts it into focus.
Yeah, I mean, not to say that mania is always this wonderful, crisp, happy experience, and people experience it as, combinations of depression and mania and irritability, and it can be very difficult for families. But some people have this sort of elated, creative high that they don't want to get rid of.
Exactly, exactly. Okay, so let's talk a little bit now about the family's role.
Yeah,
There are, why don't you walk us through sort of the um, sort of best possible candidate for family focused therapy and what they would actually be doing
sure.
in the process?
Okay, so let's imagine a family with a kid, say between the ages of 16 and 25, who's having their first manic episode and they're in the hospital. Family doesn't know what to do. Kids in the hospital. There are all these medications coming on board and various people coming in and out and testing for this and that. And then suddenly the person's discharged and they're told, okay, you need to take lithium. And we've got them on an antipsychotic as well. And hopefully he won't take these antipsychotic forever, but for now he's got to stay with lithium. Now, that person goes home and he's still manic, or he's cycled into depression, or she, as the case may be, doesn't feel like she can go back to school because she can't concentrate, or everything looks like gobbledygook on the screen, or um, and then at that time there's often a lot of denial. This was a fluke. It won't happen again. And it must have been that marijuana I smoked 6 months ago. It's probably laced with something. It can't really be a lifelong illness. So there's a big temptation to go off medications and
Mhm,
say, let's
mhm.
forget all about this and see if I really have this illness. That's where the family working with a clinician about what this disorder is and how to recognize early warning signs is very important. So we bring in the family as soon as we can after the hospital discharge. Maybe we even make contact with them while they're an inpatient. We meet with them weekly, the parents, the person with the disorder, siblings sometimes, depends upon their life and whether or not they're able to, or maybe there's a guardian, a grandparent involved. And first thing we do really is to say, tell us what you've been through. We'd say to the person, the person with the lived experience, we say, you're the one who's really gone through this. You're the expert. So educate us about what it felt like when you're getting manic. So we have a handout. We show them this is what mania looks like. Can you do? Maybe I even have a copy of it here. I can pull up quickly. Yeah, looks like this. So we'll say, um, take a look at this handout and tell me which of these symptoms you remember having. So they look through it and they say, well, I certainly had increased energy. And yeah, couldn't sleep, even though I wanted to. Um, I was really racing fast. Parents often chime in and yeah, and you were really irritable to everybody. Maybe they don't remember that. Then we get the family to talk with them about what did the episode look like? Did it have stages? What was the first sign that you were feeling different? Well, I remember he was kind of up late at night and seemed to be walking around the house a lot. Or um, she suddenly had all these schemes in mind about AI programs she was going to develop. And she was suddenly got interested in music, even though she'd never played an instrument, was going to become a musician. All these thoughts started to come up. And then she was staying up later and later, maybe going out more and more, and making not making sense. And what did the person who went through this feel at the time? Can we identify what we call a prodrome, the early warning signs? Because that's going to be very important for recurrence. Uh, and what we'll do during education eventually is we get around to what we call a relapse prevention plan, which would be such things as what do we think triggers this? Changes in sleep wake cycles, breaking off a relationship, a new job. Are there any events that are relevant? But what are the prodromal signs? What are the signs that a person's getting ill? And what can the family do? Well, some of the things they can do. I'm sorry, were you going to ask a
No,
question?
no. I was going to ask you what were some
Yeah,
things the family can do?
sure. Well, of course, the obvious one is getting in for an emergency medical appointment. Maybe the medications aren't right. Maybe the person stopped taking the medications. Maybe they weren't right in the first place, or the dosages need to be adjusted. That's one thing. It may be necessary to get the person to a hospital. And if so, do you know ahead of time which one and how to arrange a hospitalization? Or are you kind of trying to learn about the health system from square one at a time when you've got an emergency on your hands? Can the person maintain regular sleep wake hours or at least a routine? Maybe they can't sleep so well, but if they're not fully manic, they can get something to help them sleep, which might help with stabilization. Uh, can they track their mood over time? That's a good thing to do when they're well, to know here's what it looks like to feel manic. Here's what it feels like to be depressed. What's my usual baseline? And sort of keeping track of, matter of fact, I have one of those too. I'll show you. Um, by the way, let me know if these slides are distracting.
No, they're wonderful. Thank you. Uh,
Sure.
I'm
Uh,
wondering how often folks are discharged from the hospital with a complete discharge plan. Um,
mhm. Yeah.
it,
Let me just quickly show you this, what a mood chart looks like. There it is. So here's an example of keeping track of your mood. This chart was developed by a 13-year-old girl in our clinic, and she didn't like the terms manic and depressed. She had these other terms she used, like super hyper or energized or down or angry. She kept track of her mood over the course of a week. There was quite a bit of variability. There was also variability in her sleep patterns, which she kept track of at the same time. This kind of information can help not only the person, but also the family to know, where are you in this cycle? Do we know if you're getting depressed? Do we know if you're getting manic? And it's very easy for families to mislabel it, to say, I think you're getting manic again, when the person is just excited or enjoying themselves or laughing. And that, of course, the person feels very stigmatized by that.
Very pathologized, as though
Yeah.
everything that they experience emotionally has to in some way be associated with their bipolar disorder. Your graph there is very similar to the tool that we've developed, which we could call the toolkit, which allows parents and patients and other caregivers to daily input these symptoms and to graph them over the week, the month, the year, to see those patterns and from diurnal to annual. Um,
Yeah.
but I also love the fact that she was identifying these things not as not using clinical terms. We group them around things like emotions that are the most distressing, things that are scary,
Yeah.
disruptions in sleep, to really put them in the language of the person who is experiencing it, rather than in the language of pathology.
Yes. And of course, you have to consider age and developmental stage with that, because the younger kids, you probably do want to use a happy, sad, angry, energetic, whatever. But when you get to 18, 20-year olds, they know about this illness, they've heard about it, and, they want to rate it on what they consider to be their state, which might not be something as clear as mania or depression.
So I want to talk for a minute about communication, because a lot of what you've talked about so far is, asking the family to tell you as the clinician what it is that they've experienced, how it is that they understand what they've experienced. And and that's very much about from caregiver or patient to provider and back. Um,
Yeah.
And I really want to get into talking about the communication patterns within the family. But
Yes.
but before we get there, there's a question from the Q&A that I want to pull in. It's from someone who says many providers label parents of young children, um, as sort of having highly expressed emotions, when the parent's perspective is, I'm trying to advocate for my child. Do I have a child who's mood unstable and is 6, 7, or 8 or 9 years old? So do you have any suggestions for parents and families on how to engage in that communication with their provider in a way that they're more likely to be heard and not dismissed as a helicopter parent or someone who's trying to control their child?
Yeah. It's a very good question. First, I think it's important to distinguish what is a high expressed emotion. It is not something about how you interact with your caregiver, with your doctor. That's a misuse of the term. Express emotion refers to families where there's a high level of criticism going from the parent to the child, and usually taking the form of, you're not trying hard enough, you're acting obnoxious on purpose, you're being oppositional, these kind of trait attributions where there's not a knowledge of the illness, so that there might be something biological going on, or hostile statements, which are rare, but sometimes you hear, you're not my son, or you're not, I never wanted you in the first place, or there are families who do that. There are also families we call emotionally overinvolved, where and that doesn't tend to be applicable to young kids. I mean, what does being emotionally overinvolved with a 6-year-old mean? It doesn't really have meaning. When you have a 20-year-old and you have a parent who's kind of doing things for them that they should be able to do for themselves, that's what we're referring to. Now, the reason that's important is because study after study finds that kids or adults in these highly expressive environments don't do as well. They have more recurrences. And that's part of the reason we do family therapy, is to help the family understand this is not being done on purpose. This is something that is living inside the person's brain and they don't have entire control over it. That doesn't mean you can't have expectations or set limits, but know that it's an illness in the same way that hypertension or asthma or multiple sclerosis or any number of other biological illnesses, diabetes. You wouldn't blame someone for having those behaviors or those symptoms. Now, you ask the question, how do you advocate with your provider? Unfortunately, that's partly who is your provider? And are the providers people you can advocate with? Are they people who listen? Do they get you off the phone as quickly as possible? Are they not willing to consider alternative treatments? Do they meet with you and listen? Or are they sort of a quick, hey, here's your prescription, go now. If you have another problem, call the therapist. That's not the doctor you want to have. And unfortunately, sometimes you don't have a choice. Your insurance company may not have other doctors, but it's always a good idea first to bring up these issues with your physician. You don't have to bring it up in a negative way. Say, I don't know what to do. I have a lot of ideas about what could help here, and I need to be able to have input into my son's treatment plan. Can you help me? That's one way to put it. If it's just you're hitting a brick wall, you got to find another provider. Sometimes support groups are great in that context. NAMI, National Alliance for the Mentally Ill, Depressive and Bipolar Support Alliance. That's one of and of course the groups you run. Some of the groups are for that very purpose, helping people to know how to talk to their physician. When people say, oh, you're just being a helicopter parent, first I would ignore that. And I would also start thinking about, is this the right person to be treating my family?
Beautifully said. Thank you for that. All right, so let's transition into talking about these communication styles within the family. You already sort of identified some negative communication styles and comments that get made, and shared that they were relatively rare. But what sort of patterns in family communication do you see really affecting the child's mood disorder symptoms, and what ones are either the most damaging or the most useful in terms of recovery?
Sure. First, what we tell families is we don't have any evidence that communication per se has any causal relationship to bipolar disorder. We know that good family relationships and supportive family relationships are a good predictor of a good outcome.
Mhm.
But we don't say to people, you had bad communication, therefore we got to fix it so your son can do well. What we tell people is you're dealing with a biological illness which recurs, and that really requires your family to be extra efficient in its communication and extra supportive beyond what you might have to be if your kid was okay. Now, to do that, the first thing you do is make sure the family knows they're going to be talking to each other as much as they do you. The wrong way to do family therapy is for the family to talk to you and you talk back to the family like they were one big person.
Mm-hmm.
No, there's four people in the room. They should be talking to each other. Now, unfortunately, I find that Zoom sometimes interferes with that because you can have, I mean, sometimes it's great because families come in who wouldn't otherwise. But sometimes you got dad at work at his office, and then you've got the kid upstairs, you know, taking a break from video games, and mom downstairs, and the sibling somewhere else, and they're all on this Zoom where it's almost like you're a Netflix video that they're watching. And
Mm-hmm.
they're asking you questions and you're giving responses. That's not what we want to do. We want them in the same room talking to each other. And the way to start that is when we bring up symptoms in the first place, we say to the son or the daughter, okay, you've been through this. Tell your mom what it's like being manic. Tell her what it's like being depressed. Now, mom, can you summarize what your kid just said? Feed it back like you're just summarizing, like a therapist might.
Mm-hmm.
Now tell her or him what it's like for you when she's depressed. what do you find you're confused by? One of the things families say is, I don't know what to do to help you. I try to, be supportive, be kind, and be encouraging, but you get mad and you want to lock your door and you don't want to talk to us. And what can I do to help? That's part of what we talk about. Is it just leaving the kid alone? Are there certain supportive interactions that would be more helpful? Usually just listening is what all the person needs. Um, when the issue of suicidal ideation comes up, that's when families really freak out. And sometimes they jump in and I'm going to make you better and we're going to get you, hooked up with a hospital. And sometimes all the kid needs is somebody to listen
Mm,
and understand. And it's a tough judgment call because you don't know how serious the person is. Those are
right.
the sorts of things we talk about. Or here's another example. You want your kid to go to bed earlier because you're seeing that their chaotic sleep-wake cycles are contributing to their symptoms. How do you say that? Do you say it, you better get to bed on time if you want to use the car tomorrow? Mm-mm. You want to
Right.
say, I'd really appreciate you taking your illness more seriously. And one of the ways you can do that is to have a regular sleep-wake cycle. We've talked about that. Can you help us with that? And can you take full care of your own health in this way rather than me being a helicopter parent?
It's so interesting listening to you describe all of this because it really highlights the degree to which the psychoeducation component
Yes.
of family focused therapy is so important because it really requires the loved ones and caregivers who are there to be fairly well versed in the disorder itself and depending upon age, having that patient really understand what their diagnosis is and what its symptoms are as well, so
Yeah.
that they can even begin to have these conversations.
Yes. And the truth is, the disorder can change over time. Episodes can get either closer together or further apart. The symptoms can be somewhat different from one episode to another. So it's a lot to learn and keep in your head. And of course, we want the person with the disorder to learn that too, because it's their life. Their parents are not going to be around forever and they want to be able to take care of themselves. And at some point, usually late teenage, early 20s, they start being able to do that. They start knowing, hey, I got to get to bed. I can't go to that party. I can't get drunk. I can't take those drugs. I can't stay out all night. And that's a hard thing to accept. But the people who do well over time are the people who can accept that. Now, there is one problem, which is that there's a lot of information out there now online about disorders like bipolar disorder, schizophrenia, and not all of it's true. There are people who say, "Oh, just do this herbal diet, or do this, take this pill instead of that one, or
Stop
this
eating red
exercise."
dye.
Yeah, stop eating red dye. Don't get vaccinated for God's sake, or it's marijuana. Or marijuana is the thing you should be using because that's the only thing that really stabilizes mood. There are people out there who say that stuff. You have to look for genuine sources of information. Uh, Organizations like NAMI or the National Institute of Mental Health or DBSA, any of those have very informative websites, and that's where I would go first, rather than TikTok videos.
Right, exactly. So the psychoeducation is part of family focused therapy
Yes,
as groundwork that's being laid to facilitate the communication.
yes,
And then I would imagine that the communication piece of it is also essentially laying groundwork for the problem solving skills training that the families need to engage in because and they really these things build on each other. You can't do the problem solving skills if you don't understand
yes,
not only the disorder but what's going on a very individual basis with your loved one.
absolutely. And you have to be able to talk about it before you can solve problems. Solving problems involves everybody talking about their point of view and what they see as the options. and coming up with a balanced way that isn't just favoring person's point of view. You know what, Elizabeth? I have a little vignette of a family therapy session with communication training in it. And although it's written, I think it'll give your audience some sense of what we do in these.
Wonderful.
Let me pull that up. Okay. All right, here it is. All right, so here is a list of the kinds of communication skill. Uh, darn, went back to where it was.
That's all right.
There it is. This is a list of the communication skills we teach. We always start with the positives. You know, what has the person done in the last month or two that you liked? Might be something as simple as, I really appreciated your taking out the garbage. I didn't have to do it. Believe it or not, that kind of stuff is really important to someone who's just gone through an episode. They think they're a burden on everybody. They don't think they can do anything right, especially if they're depressed. And some basic positive feedback is always a good thing. And likewise, we tell the patient, there must be some things your parents have done in the last month that you appreciated. You're saying all the things you don't like. Can you bring up one of the things you did like? And they think for a while and go, yeah, I really liked that dinner the other night. All right, would you
We
tell your right? What's
No,
that?
I was just going to say we call that catching your child being good with
Yes.
good in quotation marks. Just calling out the positive engagements, the positive interactions, so
Yes.
that they know that these things are being seen and appreciated.
Right. And of course, our population is a little older, but it's still equally important, though, that they hear what they're doing right. So they might be a teenager and they might say, oh, my parents are idiots and blah, blah, blah. And I hate my parents. But it's still important to them to hear, you know what? We know you're trying. We appreciated how
Exactly.
kind you were to grandma last week, or the fact that you took care of the dog so well, or that when we were out of town, you made sure that X and Y was going to happen. That sort of thing is very important. Like I said, active listening, talking, paraphrasing other people. We do this with role playing. So we'll say, Dad, I want you to talk to your daughter about a problem you had at work today. Let's start with something neutral. And the kid's only job is to summarize and paraphrase the feelings and how to get resolved. Kids aren't used to doing that, but it opens up a line of communication. Then we
Hmm.
switch roles and say, okay, now you talk, dad listens. I'm going to give you an example of positive request for change. How do you say to someone, I want you to do something different without it sounding like a criticism?
Right.
So and these are the steps of active listening, attending, nodding your head, asking questions, paraphrasing. You don't have to have ears like that, fortunately. But so this was a family with a father, a mother, and a 16-year-old boy who just had bipolar 1. And he was out of the hospital. And he had some suicidal ideation, but he also still had some manic symptoms. The father started by saying, I really resent the hours you keep. You always come in later than we've agreed on. You're loud. You wake us all up. Makes me think you don't take your illness seriously. Okay, well, that's clearly criticism. It's also a negative attribution. You're doing this on purpose to be obnoxious. Son does the one size fits all response of all teenagers, rolls his eyes, whatever. You have to choose to get to sleep on time so you don't go wacko again. All right. Once again, an attribution, you're doing this on purpose. The point is there, but it's not very positive. Mom tries to jump in and Larry, let's not get into this again. What is the therapist going to do here? So the therapist starts by validating the dad. And by the way, this is not natural for clinicians. They think, oh, I got to call out that criticism. Tell the parent they did something wrong. No, you start by saying, I know what your intention was. Your intention was to be helpful. Dad, I can see it upsets you when Evan comes in late, wakes everyone up. You're angry. You're also concerned about his health and well being. That's true. He said, I'm worried about you getting sick again. Dad, of
Mm.
course, likes that and says, of course. But consider how you're delivering that message. You care and you don't want him to get hurt, but I'm guessing he only hears the anger part. Evan? So Evan says, yeah, that's all I ever hear, one criticism after another. No matter what I do, he's always pissed off. So, Dad, maybe you'd be more effective in getting your point across if you said it in a more positive way. So, we introduce a handout, making a positive request. How can you turn this into a request? What do you want him to do differently? How would you feel if he did it differently? Give Dad a little time to think about it. Remember, it's got to be positive. I'd like it if you did this or that differently. So Dad looks at the handout, says, okay, Evan, I'd appreciate it if you would come home earlier and at least let us know if you're held up somehow. That would make me feel like you weren't just blowing me off as usual. Okay, so
Okay.
that's what we call a sting in the tail,
Right.
right? The person started off positively, but now now it's a criticism again. Therapist says, good start, wants to reinforce the dad. Evan, what do you think what dad just said? It's always better when the feedback comes from the people in the family rather than you. Evan says, well, the first part was okay, but was that what he was supposed to do at the end?
Smart
Therapist
kid.
says, yeah, exactly. Therapist, dad, can you say that again? Only this time, try to add something positive about how you would feel. So dad tries again. Okay, Evan, I'd appreciate it if you would come home earlier. Let us know if you're being held up. Text me or something. That would make me feel like I'm being respected. All right, pretty close. Therapist says better. What do you think of how you said it? Your dad said it that time. Evan said, well, he said it a lot better. I don't know if I'll do it. Dad says, you will if you want to keep using the car. Now, the therapist has a choice here. Therapists could go into problem solving about use of the car, but that's not what we want to do. We want to teach them communication skills first. So we say, Dad, nice job with that request. Let's talk about how you might practice this type of communication at home.
Hmm.
Evan, do you want to make any requests of your dad about this topic or about anything else? Can we set up some quid pro quo agreements? That's how we merge into problem solving.
Right.
Now, it isn't always that smooth. Sometimes you have to go teach people how do you express a negative feeling as well. We've talked about this. I'm angry. I'm angry that you didn't do something about this. What are we going to do about it? How are we going to fix this? That's better than, you did this, you did that. I'm mad because. So that's really, and of course, the core of communication skills is getting people to practice in between sessions. They can do it kind of like performatively while you're there. What happens when they get home? And that's why we have them do these homework assignments and bring them in, and we kind of say, well, what worked here, what didn't, what still
And
needs work.
and how does this new method of communication become the default
Yeah,
rather than something that requires thinking about in order to reframe that
yeah,
those questions, those communications are being framed in the positive
yes. And if you
as a matter of
can,
course.
and if you can, you can say to the parent, when you find yourself mad, steaming, and you want to say X or Y, that's when you got to count to 10 and think about what did we talk about in therapy about how to present this? Is this a place where I can use positive requests, or do I need to express a negative feeling to get it off my chest? And if so, what's going to be helpful? Everything has to be helpful, not just sort of a way of letting off steam.
I'm curious as we talk about this. Practice is obviously an essential component to mastering these skills, but there are going to be times when people fall back on old patterns of communication, having to figure out how to navigate conflict, times where folks don't want to compromise, don't want to frame things in the positive,
Mm-hmm.
and conflict is often a predictor of relapse. And so, how do you help families understand communications, not just around sort of establishing rules for the household or treatment plans that are or not going to be followed. But how do we work with families in a way that is specifically designed around resolving these sort of same fundamental conflicts that rise over and over and over again?
Yeah. It's a very good question, and all families have conflicts. And of course, bipolar disorder adds a level of intensity because of the fact that emotions are already running wild in the person and the family as well. And there are going to be conflicts. There are a couple of things we teach people. One is what we call the three volley rule, which is when you've said something to a kid or a person with a disorder and they've responded, and you've come back with an counter argument, and they come back with the counter argument, it's done at that
Mm.
point. That's when you say, okay, I've made my point. You heard me. No more arguing, no more justifying, no more logic. Who has better logic? The kid will try to engage you in that, particularly younger kids or teenagers. Hey, I'm smarter than you. I can talk you out of this. You don't have to engage with that. It's not going to go in a good direction. And actually, it disempowers you as a parent to have to be arguing with your kid like that. And we see that in sessions too. We see people getting into these back and forths and they're sort of interrupting each other. And first thing we say is, okay, before you make your next argument, you've got to paraphrase the other person. That's the rule. Yeah, you can say whatever you want, but first you got to say what they said.
Mhm.
You can just see the tension drop as people start collaborating more. Sometimes they get into what are the real issues. That's one way. The other is to be very specific about what you're arguing about. Um, Families, I think, sometimes get confused about the big issues versus the small ones. Is this an issue of you're not taking your illness seriously, or you're being disrespectful to everybody, or is it you left your dishes on the table?
Right.
And are they going from one small bit to this larger picture, which the person has no way of defending themselves against? Wait, I just left my dishes on the table. How come that means I'm a disrespectful son? Well, you did this and you did this and you did that. That's not going to go in a good direction. Stick with the topic you're upset about. Say, you know, how are we going to get the dishes done? We need to talk about that as a family. We recommend people have family meetings once a week where they go through these communication skills. If they can't do it spontaneously, hey, Saturday morning, everybody's at home. We have breakfast together. How about a half hour or 20 minutes of practicing this stuff? And they go, I don't know if we can do that. That doesn't sound like much fun. It isn't much fun, but try it. See if it makes any difference to practice this in between. Somebody take notes. The kid says, I don't want to do that. I don't want to do that. Okay, you take the notes then. You know,
So we have a couple of questions in the Q&A about this that I want to integrate here. And the
sure.
first is around this sort of fundamental idea that in order to do this, the family members, including the person who's been identified as the patient, they have to agree to do it. You
Yes.
know, and and they have to function with good faith that they are going to try to do it.
Mhm.
And so the two questions that I want to sort of merge into one here are first, like, what do you as the practitioner do when someone in that family unit is not acting in good faith and they are not actually willing to do it? And secondarily to that, what happens when that teenage uh, patient child in the dynamic has folks in the extended family who are not a part of the therapy, who are undermining the therapy's uh, practice?
Yes. And those are all, of course, things that we have run into. The
Yeah.
main one I think about when you bring that up are split families, where the kid is with mom on one part of the week and with dad the other. And maybe mom and dad don't agree that there even is bipolar disorder or that the kid should be taking medications. I've had, parents call me up and say, I think this is all bullshit, what you guys are doing. My kid isn't bipolar. He just can't get along with his mother. That's the problem. Now, the first thing we try to do is invite that parent in for a separate session, either with the kid or even individually, and say, what's your take on the history of this problem? Did it just start now, or has it been going on for a while? They want to focus on their spouse, but I say, no, I want to hear about your kid. What kind of relationship do you have? How often do you see them? What kinds of behavior problems occur at your house? How do you deal with them?
Mhm.
Um, does it make sense for us to have conjoint sessions with your ex? If not, do you want to have some separate ones with your son or your daughter? We might split it into two treatments. If there's another relative, what is the role of that relative in the kid's life? Is it someone they see regularly, or is it just someone who weighs in once in a while? Is it a grandparent who comes in and every so often it says, "Are you taking your medication?" Or is it someone who's yeah, actively involved in caregiving? And if so, can they buy in? Now, our clinic, actually, we tell people at the outset, if you're going to come for treatment in our clinic and you want medications, you also have to get family therapy, and you have to get a minimum of 6 sessions. And the reason we do that is because we think bipolar disorder is very intertwined with what happens in the family, or early mood disorder in general is intertwined with it. Can you do that? Sometimes they say, oh, he'll never come in. You know what? He will. Let's bring him in for a single session and see what happens. Can we develop an alliance with that family? And then you're off and running. Doesn't always work. Sometimes you say, this is not workable. These people don't want to be in the same room together. They don't want to learn. They don't believe that the kid is ill. This is not the right time to do family therapy, just like sometimes it's not the right time to do individual therapy either.
And I imagine there would be a lot of intergenerational conflict, intergenerational communication difficulties, sort of reorienting each parent back into their family of origin and sort of looking at what communication styles and conflict resolution approaches they used with their siblings and parents that are influencing the way that they are interacting with their child, or the ways they're allowing their child to interact with their extended family. That it's much more complicated than just sort of identifying that this one person is causing the problem,
Yes.
but that
Good
it's
point.
actually
The
a whole
system.
set of yes, an interwoven system.
Very good point. Actually, I think it was the family therapist Carl Whitaker said that marital problems are a competition over whose family of origin ought to be imitated. And that always sort of rang in my head as, yeah, that there's some truth to that. It's not 100%, but people are used to a certain way of resolving conflict from their family of origin. Maybe dad was raised in a very sort of militaristic family where the kids obeyed, and the idea of the kid flipping him off and leaving the house is just, horrendous. And the fact that mom tolerates it is, even more horrendous. And you have to bring that stuff out. The other, of course, intergenerational issue that comes in is, does bipolar disorder run in either the parents' families or themselves? Sometimes a parent has bipolar disorder, and that unfortunately can lead to what we call genetic guilt. You're the one who gave him this gene. It's your family, it's your crazy mother, it's whatever biology in your brain that he happened to inherit, and it's your fault. And we really dissuade people from thinking that way. We don't know how it's transmitted. We don't know that it's only from one parent. We don't know whether that makes a difference, that it's genetic. It might mean that they respond to the same medications. But other than that, it's not very helpful in coming up with what's going to help the family.
So, when we're looking at families who might be interested in family focused therapy, is there a sense of what characteristics are going to be the most indicative of success?
That's a good question. I would say this first. Is this a family where the kid as well as the parents are worried about what has happened and want to learn more about it? Where the kid is going, something pretty awful just happened. I had this episode. I didn't like being in the hospital, and I don't know what it is, but I want to know more about it. And parents, of course, often feel that way as well. That's a good prognostic sign. We want to work together to make sense of this. And if that means changing our communication, if it means being more resilient or more permissive about this or that, or more structured, we're willing to do that. Where I think it goes wrong is when there's blame. This is because you did this, or you didn't parent in this way, or you gave the wrong genes, or my kid is just oppositional and that's the problem. He's always been oppositional. That's not a great prognostic symptom for any treatment, I think. You have to be flexible and realize the person can change, even though it might be a long haul.
Are there other sort of cultural factors that have to be taken into consideration? I'm thinking of the difference between, uh, the more individualized Western cultures that really place value on individual autonomy and choice versus more collectivistic approaches to family dynamics.
Yeah, that's something I've given a lot of thought to. In fact, there's a really good book on this called Ethnicity and Family Therapy by a woman named Monica McGoldrick. It's kind of a classic in our field. And she actually uh, goes through various ethnic and racial groups and talks about what are some of the values and styles of communication. Um, People don't tend to think about it in that categorical way anymore, but there is some value to that, I think. One thing you can do is to say, what do you believe about this in your culture? Particularly if it's somebody who's a recent immigrant or, identifies strongly with their cultural group. What have you learned about mental illness in your culture? And let me see how it matches up with what I think to be true. I'm not saying I'm right and you're wrong. It might just be a different frame. But um, I remember seeing a film a long time ago about a guy with schizophrenia on the island of Borneo.
Hmm.
And he and his wife, he was hearing voices from what he said were ancestors talking to him through the rice paddies. And he went to all these different um, uh, faith healers. Somebody blew on his stomach. Someone did, poured water on him, did this and that, culturally appropriate. And all the people who they interviewed in this film did believe that he was talking to his ancestors. But at the end, they interviewed the couple and asked them, what do you think was one of the most helpful things? And they said, taking that medication, that Haldol in this case, that was what really made him better. So even with these cultural beliefs, you can still take advantage of the interaction of Eastern and Western ways of thinking. Meditation has gotten very big in the US. That came from Buddhism, right? We bring in meditation all the time as a way of dealing with anxiety or agitation. Uh, but the first thing you want to do is find out what are the people's beliefs. How do they feel about medications? That kind of thing.
Right. I'm reminded of a journalist who wrote a book, the book Far from the Tree, about parents and
Andrew Solomon.
yes. And I remember hearing him speak one time where he said that, when we take into consideration the cultural belief systems that clients have. And when we engage with them in ways that reflect their belief system, but also integrate the therapist's own system as well, the greater likelihood that a space for healing is created. Because and I remember from early in my own career, watching psychiatrists who would, be looking at the blood work and say, well, this medicine isn't working, without listening to what the client was saying about whether or not the medicine was working. And that having a perspective that is either 100% the providers or 100% the clients is going to put you on unequal footing, and that finding that space where folks can share respect and build a path to recovery together is going to be much more effective.
I agree 100%. I think to me, it comes down to, do you see mental health care as something you do to someone, or is it something you collaborate with somebody on? To what extent do you bring in the person's beliefs and what they want, what they believe? If you just hand them a pill, they're not going to take it. They need to feel like there's some engagement, that they agree with you on the premises. Unfortunately, our health system doesn't allow us always to take the time to do that.
That's true. And that's an excellent segue into sort of our last topic, which is twofold. How do families that want to pursue this, how do they find someone who is trained in family focused therapy to see? And the other side of that coin, which is as a provider, if someone wants to be trained in family focused therapy as the provider, what tools are available to them?
Let me answer the second one first, because it's easier.
Okay, sure.
If you're a clinician, you want to get trained. There are two things you can do. One is, we have a book called Bipolar Disorder, a Family Focused Therapy Approach, which is a how-to for a clinician, how to do this with your patients, whether they're older or younger. That's the first thing I would do, is read that book. We have a self-training online seminar. It's about 6-7 hours long, actually. A basic introductory workshop is put on by J&K Seminars. J&K Seminars, they sell this, and I don't make any money from it, by the way. It's something they did. So in terms of where people can find it, it tends to be, there tend to be more practitioners in big city universities, Pittsburgh, Chicago, UCLA, Cincinnati. There are places like that. There are clinicians. Can always write to us and see if we have a referral that we can give. People are doing that all the time, and we sometimes are able to hook them up with therapists in other cities. It's not perfect. I give a lot of these seminars, I do a lot of training, but the number of people who are practicing can't learn every therapy. And they can adapt it to their own style. They can use some of the handouts, they can use some of the communication skills, but you're left with what they can do in their practice.
It seems to me that you've done a tremendous amount of research on the use of family focused therapy for bipolar disorder, but a lot of what we're talking about today are very basic fundamental communication skills that are used in any sort of group dynamic therapeutic approach. And so I would imagine for providers, there is really no limit to the context in which they can use this approach with their patients.
I would like to think that's true. The one thing I would say as a caveat is, you have to know bipolar disorder. You have to
Mm.
go in with a knowledge of, how do people get manic? What does a recurrence look like? How do you distinguish a prodromal symptom from being a teenager? All those things that are not easy to distinguish. I can go on and on about that topic,
I can
but
too.
I'm sure you could. But there are two parts to this treatment, really. There's the education about the disorder and bringing it up and talking about it, reducing the taboo, the stigma about talking about it. And then there's how to talk, how to solve problems. Two different parts. And I think you really need to know both. But
Absolutely. As you said earlier, you can't solve the problem if you can't talk about it, and you can't talk about it if you don't understand what it is.
exactly. Now, there are families who benefit just from a few sessions of family education about the disorder. And that may be all you need. Maybe they
Mhm.
don't need intensive communication training. but that's individualized.
Is there additional research that is going on into family focused therapy?
Yeah, we're doing a lot of work in psychosis now, prodromal psychosis. We are finding it's effective in the same way that when people have had, say, low-level delusional thinking and negative symptoms, they're at risk for schizophrenia. Doesn't mean they won't that they'll develop it, but they're at risk. They do benefit from the family learning some of these same skills, some of these same management skills. Um, it's been used with depression. My colleagues at Boston University, Martha Thompson, has used a version of family focused therapy with kids with depression, Jonas Arno. So I think it is that's part of what's going on. We're also trying to understand what changes in the brain when people undergo therapies like this. We do neuroimaging pre and post treatment, try to understand, and this is part of what we call personalization of treatment. Who are the good candidates? Can we demonstrate that it's worked at the neural as well as the behavioral level? Those are some of the things we're looking at.
Well, that sounds exciting, and I'm looking forward to hearing more about it as that research progresses. We are out of time for today, so I want to just give you a chance for us to just wrap up, check in to make sure there aren't any final questions that need to be addressed. I would say to some of the folks who have put things into the Q&A, some of these are personal questions that you're asking, which is why we're not addressing them for the group, because we are here to talk about the therapy in general, not for individual people. But there is one comment here that I would like to read, and this person says, "Thank you. As a parent and as a therapist, I thank you for this. There is a long way to go in my own community as far as stigma and bipolar disorder, and I am encouraged that it is possible to make process. I find it fascinating that group therapy is so very powerful and that peer support groups are often more useful and powerful than individual therapy when it comes to understanding bipolar disorder because we can learn from each other."
Fair enough. And I think one other message I'd want to get across is for families is don't give up, because sometimes what you're seeing now is not what you're going to see in the future. It might be very hard right now. You might be seeing a lot of recurrences. Some of these same kids look really good down the road, and they may be stable. They may have found themselves or matured, their brains have matured in various ways. So never have a negative prognostic view of the future. Lots of things can change.
Well, that's a wonderful sentiment for us to end on today. I think a lot of families can feel helpless and worn down after years of treatment. And it really sounds as though family focused therapy is different. It is not the treatment as usual. It is a way to create new forms of communication, new pathways within relationships so that families can, as you said, look to the future as something that is hopeful, and that there is a great possibility for improved quality of life as a result of engaging in this process.
Thank you. I appreciate it.
Well, thank you so much for being here with us. This was fascinating and informative. I will have links to your 3 books available in the description and notes of this recording when we put it up on our YouTube channel. I encourage everyone to take a look at Dr. Miklowitz's work. It is extremely important, and it can change the trajectory for people's lives. So thank you again for being with us.
Thank you, Elizabeth. This was a lot of fun. Good to talk to
Good to talk to you again. Thanks, everyone. Good night.
you.